So our presenter is Okomfo Efua Nsia, also known as Sloan Sanford. Okomfo Efua Nsia recently graduated as a priest to Nana Essie Ketwa under the tutelage of Nana Yao Yarenchi of Perry JB I. She has a background in global health that spans more than 20 years with experience in project management, intervention design and implementation, program assessment, monitoring and evaluation, qualitative data collection and analysis, and coalition building across a wide array of health issues, including maternal and child health, minority health, metabolic diseases, and cancer disparities. While working mostly on projects concerning maternal and child health, she considers herself a global health generalist and has worked on varied projects, including conducting capacity and needs assessments of Mali's public health clinic and laboratory infrastructure in Bamako and surrounding rural areas, assessing Guyana's largest public hospital's midwifery training program, and in Geneva, Switzerland, while as an interim at the World Health Organization, analyzing how well member states implemented recent amendments to an international agreement in support of public health needs in low and middle income countries. With the blessing of Nana Yao Yarenchi of Para JB I, she will lead efforts to develop a health clinic in Nyamabichere in Koforidua, Ghana. She holds a BA in Cultural Anthropology from Howard University and is a member of the illustrious Delta Sigma Theta Sorority Incorporated, my soror. So, had to add an extra smile for that. So just want to go over a few notes before Okomfo Efua Nsia begins. Again, as you know, if you have any questions, please type them in the chat. If there is a discussion and you would like to be added to the list to speak, please type your name in the chat. And we are going to get, we also ask you to remain muted just so that everyone can have clear audio throughout the presentation. So we look forward to a very enlightening and lively presentation. So please join me in welcoming Okomfo Efua Nsia.
Thank you, Ajua, for your very gratuitous introduction, and a shout out to DST. So this is a topic near and dear to my heart. Global health is the one thing that I would do besides being an Okomfo for free for the rest of my life. I happened upon this field in the very early 2000s as a research assistant at the Human Genome Center at Howard. And I've been in love with the field ever since. However, it is definitely problematic. There are many issues within the global health field concerning race, concerning who's deciding what is important in global health, where the money goes, what issues are being talked about, what issues are of concern, and whose concern are they? And is Africa really being developed? Is Africa really being, really benefiting from these efforts? So this is me right there. This is in Mali in, I believe it was 2018. I was there with the University of Maryland in Baltimore on a $23 million grant received from the Gates Foundation to look at how an antibiotic, azithromycin, you know, when you go get a Z-Pack, the drug is called azithromycin, and how azithromycin could be used to reduce infant and maternal morbidity and mortality. So the drug had been, it's an off-label use of the drug, meaning that it wasn't originally created or put through a clinical trial for the use in what we were looking at. But there have been maybe 7 or 8 other studies that were published about the treatment effects of azithromycin and how it could benefit women and children. It had been tested in a number of countries and throughout West Africa and also East Africa as well. And for the most part, it showed to be promising. So I will follow up on that in a minute. So what is global health? There are many definitions. There are 3 here that are pretty popular. An area of study, research, practice that places priority on improving health and achieving health equity for all people worldwide is one definition put forth by Kaplan. Those health issues that transcend national boundaries and governments and call for action on global health forces that determine the health of people. And lastly, a collaborative transnational research and action for promoting health for all. So these are 3 definitions that are more or less kind of considered the definition of global health on paper. But what probably most of us think of and what we see is a north-south approach. Rarely do you see, and by north-south, I mean global. So the global north is considered North America, Canada, Mexico, Europe. It usually goes from the north to the south by way of funding, by way of direction, by way of mandates, by way of insistence. Rarely does it flow south to north. And I wanted to talk about the roots of global health. How did this become a thing? How did this become a field? The roots of global health are from colonialization. So as early as the 16th century, when Europeans came to the continent to conquer and install their colonial headquarters, they got sick. They weren't from this environment. They didn't know how to deal with the diseases. They were confronted with diseases they didn't know what to do with. And so the field of tropical medicine, that is the first name of global health, came to be, where European doctors and other medical professionals began to travel with the colonizers to care for them. And this was mostly dealing with a population health level, and as opposed to treating individuals. So when you're dealing with population health, you're looking at pandemics, like what we're dealing with right now. Like, how do you lessen the transmission and the severity of a disease so that everyone doesn't get sick? And so the primary focus was on the Europeans and not the Africans. Now, they would eventually treat Africans, because if you have everybody in one place, everybody can get an infectious disease. So you have to control the disease in everyone that's in that area. But it was not intended for the indigenous folks there. Later, as this became a more militarized operation and setting up these colonies, military health developed. And that was a very brutal situation for the indigenous population there. So this is when you start hearing about experiments, going on the continent. Folks being treated literally like human guinea pigs, limbs being cut off, experiments being done before any type of international bodies existed to regulate those types of things. And then later, we have, and this is more into the later 18th century and the early 19th century, you have the religious medical missions. And this is where we get our white savior complex coming. So now, after you have the colonies established, you have the military units, then in came the religion. And this was also the start of what I call the generic food for, and then fill in whatever the blank is. So I'll give you food if you take this Bible. I'll give you food if you abandon your religion. I'll give you food if you give me access. And then you can fill in the blank with what took place. And then now looking at the new term that is being used, global health and post-colonialization, it's continued and it's been formalized in the NGO or the non-governmental organization space. It still largely, but not totally, operates within a colonial framework. It's still the Food for programs. It is a largely white ran, white operated, white funded institution. It's for us in the US who work in global health, is largely supported by the US government through appropriations from Congress and also line items in the administrative budget. The World Health Organization, which is all known to us, even though it has about 149 member countries, it is largely funded by the United States and the Gates Foundation. Those are the two biggest funders of the World Health Organization. I believe the US kicks in 300 or 400 million, followed by the Gates Foundation with about the same amount. So they bankroll the World Health Organization, which is important to know. And why is this field so important? Because diseases spread. And I think, we have a very shiny example right now going on with COVID. It takes one person and one plane ride for a disease in China, however it got there, to then circulate around the rest of the world in days. And given the cheap price of plane tickets, you can get to Europe for $300. I've seen those tickets. You can get to Ghana for $800. There are a lot of people traveling. Airplane travel used to be very exclusive, but it's not anymore. So you have thousands of people, trekking across the globe, easily spreading infectious illness. So it's important, whatever happens in the Philippines, whatever happens in China, Ghana, in terms of an infectious disease, we always have to be concerned about that here. Also, global health today is sexy. Everybody wants to be in global health. Everyone, pretty much every major university has some sort of global health program. It's a highly sought after field of study. You can earn, some places you can get a bachelor's in global health. Most places you have the MPH, DRPH, PhD that you can get with a concentration specifically in global health. It's also a major source of employment in the United States, and the hubs are mainly concentrated here in DC. I would say DC is the largest hub for global health, especially if you're working in global health policy. There are probably 50 organizations, easy, right inside the district. Next, I would say, is New York, because you have the UN there, of course. Raleigh-Durham is another hub with UNC and a couple of NGOs that are in Raleigh. And then, of course, in Seattle, due to the Gates Foundation. Also, it is an $11 trillion industry. And I had to do a double take when I read the number, because I'm like, this can't be right. So I checked numerous sources, but yes, it's a high stake industry. There's a lot of money involved. There's a lot of money flowing back and forth between countries. And it's following the money with global health is tricky. Recently, there's a term used to apply to the industrialization of global health, and it's called the global health industrial complex, and it's akin to the other terms that we've heard that apply to, like the prison industrial complex. So now this is a term being floated around global health spaces and medical anthropology and medical sociology spaces, where people are starting to really look at and be very critical of the money flows in global health. And not just the money flows, but also the health outcomes and what we're seeing in countries that are supposed to be receiving this money, receiving this aid. So the US global health funding, and this is in a million. So just for the US, you're looking at $11 billion. And this is coming from our government. So the largest, closely 50% is going to HIV, and then to the Global Fund for HIV, and there are a few other diseases that are part of that. MCH, that's maternal and child health, malaria. You see this FPRH, that is reproductive health, global health security, tuberculosis, nutrition, NTDs are neglected tropical diseases, vulnerable children, and another 310 million coming from the US. So some of the major disease and issue areas that are often addressed in global health interventions is, and I put this in bold, maternal, newborn, and child health for a couple of reasons. The conversation we had yesterday, some of you were very much interested in this area in terms of what is going on in the US with African-American women and maternal mortality and infant mortality. This is also a huge issue across the continent of Africa and in other areas of the world. Then you have WASH, or water, sanitation, and hygiene, HIV, AIDS, Ebola, dengue, malaria, vaccine development, and then you have NTDs, neglected tropical diseases. They're called neglected because they don't get a lot of money put into them because no one else gets them. These are very localized illnesses, but they're very damaging. They cause stunting, and they also cause cognitive development issues. So while they're important in the past and kind of in the present, they have not received the attention that they have. That is starting to change. So where does this money go? Largely it goes to US and European NGOs, and they usually lack diversity. I had the opportunity to work as a fellow for the Global Health Council here in DC about 6 years ago. And the Global Health Council served as kind of an umbrella organization for global health policy and advocacy NGOs. And the reason this is important is that advocacy is a nonprofit way of saying lobbyist. And it's the way that you can lobby Congress without having to have a lobbyist license. And so these folks they have actual roundtables that are by disease. So you'll have anybody working in HIV AIDS, they all meet, at a set amount of times. Malaria, the NTD people, the MNCH people, the WASH people, they all meet, these different organizations, and they get together and they decide what their ask is. How much money they're going to go and ask Congress for, how much money they're going to go and ask the administration for. They essentially set the priorities of the US government for global health. They inform the government what's important and what money should be spent on in global health areas, what countries need the money, what should be a priority. And so I had the opportunity to do a qualitative study of a landscaping exercise of these organizations. And I interviewed their lead policy experts from 23 different organizations. And I got to go and visit and observe and sit in on their meetings. And out of the 23 organizations, I met one person of color. Make that two. I met one Black person, African American, and one Indian person. Everyone else involved, everyone else at the table, with the exception of the HIV/AIDS roundtable, because that included organizations addressing domestic issues of HIV/AIDS. With the exception of the HIV/AIDS roundtable, all of these roundtables representing all of these different organizations did not have, for the most part, anyone from these countries, anyone of the same hue as folks from these countries representing them. And the vast majority of global health plays out in Africa. Of course, Asia receives it, but overwhelmingly, a lot of this, it goes on the continent of Africa. Rarely does any of this money go into Black-owned or operated NGOs. First of all, there are hardly any anymore. When I first got into global health in 2002, 2003, I think you could still count on two hands the number of US Black-owned or operated global health NGOs or development NGOs. And that number has dwindled. I believe AfriCare may be the last of its kind. And that has been touch and go on whether or not it's going to stay in business. Rarely does this money go to systems strengthening or building infrastructure in the countries. And actually, I was told while I was a fellow with the Global Health Council that you don't even utter the phrase when you walk into Congress. You don't talk about building infrastructure. You don't talk about system strengthening because you will automatically get the door in your face. Congress didn't want to hear about long-term projects. They wanted projects that were quick. They wanted projects that could be achieved during their stay in Congress. If it was anything that would run past their term, they didn't want to do it. And this is important because during the Ebola crisis in 2014, which devastated Liberia and Sierra Leone, system strengthening was one of the key areas because they lacked systems in place and they lacked infrastructure. This was the main reason that Ebola was able to proliferate and spread throughout the country so fast, because there were no systems in place to get supplies out, to mobilize staff, to communicate. They showed pictures of ambulances sitting in a warehouse. There was no gas for the ambulances, and there were other technical issues, or equipment comes in. They could use it for a while, but then it breaks down. There's no technician trained to fix it. So you will find these sorts of issues going on throughout the continent. You might have even witnessed some while you were there. And even more rare, does any of this money go to actual ministries of health? The money is usually going to a US or European-based NGO. A large part of that is overhead. It's paying people's salaries. It's paying for airfare. While I was an intern at WHO in Geneva, I was there for a summer, for a 12-week internship, and I witnessed someone travel. Maybe, I think it was out 4 or 5 trips. 4 or 5 trips in a 12-week period from Geneva for things that could be done on Zoom, honestly, and Zoom existed at the time. And so when you think about the money, the overhead, the salary, the shots, the hotel, the reimbursements, a large part of this chunk is not ever actually going to the continent. It stays in Europe and it stays in the US. And then I think one of the most understood, the least understood aspect is the people, the culture, the religious practices, the economics, what stimulates the economy, what doesn't. A lot of times projects are not thought out and they don't take into consideration the landscape, the current political system issues that might come up. Are we going to, is this project going to be in line with people's customs and their practices when we implement it? So is it something that'll be sustained, or are we going to helicopter in, impose this, this project, tell them it's good for them, give them food or give them whatever, they say yes, and then we leave and then it stops. That happens a lot as well. And so I have a little project for you all. Let me come out of here. I want to see how many people are in the group. Ajua?
40.
Okay, that's a really good number. So I have this little map of a country called Fredonia, and I was trying to draw my map in some program, and I'm not computer savvy enough, so I sketched it. I hope you can see it. But this is an exercise that in my graduate program in public health, one of my professors did. He gave us a made-up country and then told us we needed to get food and supplies across this country. So if you look in the middle, this is where you're located. Up to your north, you have Christians and traditionalists. There's also a mountain range separating you. To your left, over here, I don't know if you can see my cursor moving, but you have a little bit of everybody. You have Christians, you have traditionals, and you have Muslims. And these little lines, these squiggly lines, these are roads. And then across this river, down in the right-hand corner, you have Muslims and traditionals. And there's a bridge that goes across to where just Christians live. But it's a hot zone because the Muslims and the Christians are fighting right now. There's a bridge to get you there, but you got to get past some stuff in order to get across this bridge. And then here, the road is out. So you're here, and I need you to go to all 4 areas to deliver food and other supplies. So assume that the traditionalists are Akom people practicing traditional belief systems. You know what you know about Christian beliefs. You know what you know about Muslim beliefs. There is a representative for each belief system in every part of the country. And your food supplies, you have goat, you have cow, you have pig, you have millet, rice, sorghum, and chicken. And you need to get all of this food to all of these people in the appropriate way. And you have at your use, you have a Hummer, you have backpacks, and you have 50 people. So I want you to decide, first of all, on your team, who do you need? Remember, you have to feed everybody, and you have to worry about their health, not just the health of the people that you're trying to get medical supplies to, but also the people on your team. And then how are you going to get there? So you're going to have about 15 minutes. We're going to split into groups of 4. You're going to be randomly assigned through the breakout room function of Zoom, and Ajwa and I will circle around to all of the rooms.
I have a question.
Yes.
How long do we have to do all this?
Yes, you have 2 weeks. You mean in the world of Fredonia? Yes.
Exactly. So you have 2 weeks to get that done.
Yeah,
okay.
2 weeks, and it's the rainy season, and that's why the road is out over there.
Okay.
Okay. So I'm gonna set my timer for 15 minutes. And does anyone else
I have a question. What other resources do you have?
I just told you, you got a Hummer, backpacks, and 50 people. Assume you
backpack and 50 people.
Yeah. What I'm doing is typing in your notes in the chat so people can refer to that.
Thank you.
You said that you
have a helicopter. What's up?
Yeah.
How you gonna give me a Hummer? What am I doing a Hummer?
You got a Hummer, and not one of those fashionable Hummers. You got the real like Army grade Hummer.
Do you have a Hummer? What other resources do people have?
Backpacks.
Okay.
So let me ask one more question. The 50 people, are they laborers? Are they skilled? What's their skill level? Where are they?
You can decide their skill level.
Okay.
So I want you to tell me who you're going to take with you and how many. You have up to 50 people.
All right.
Anything else that people need to know that I should put in the chat? We know they're going to have 15 minutes to complete. I will put you in breakout rooms in just a moment. I just want to make sure everyone's clear on the task.
And I was hoping that this little map would remain visible for everyone. I'm not sure if it will. It's not. Oh, I'm sorry.
That's what I'm typing it in the chat.
So, but you probably took a picture of it real quick and then put it in each of the rooms, I guess.
Okay. Let me do that.
Okay.
And so people will have 15 minutes?
Yeah.
Okay.
And then select someone to report back, and then let's talk about it.
All right, give me one moment.
Does anyone else have questions?
I have a question.
Hi.
Hey, I got, my question is, how much money do we have? Or do we get to decide that too? Like, just like write out how much it should cost or something like that? I don't know.
You don't have money. You just have what you have right here. These are your supplies.
Got it.
I have a question. I also have a question.
There's a raised hand. Umul Tigare Kwabena.
Yes, I am not technology savvy. I don't even know if I can get into so-called chat room. I got to be honest.
Oh, it'll be done automatically.
Okay, no problem. Thank you. I don't know, and I don't know how to put the hand down either.
Don't worry about that. Then we
Okay.
have,
I couldn't hear how much money we have. The sound went off.
Oh, assume you have none. You have only what is listed here.
And how deep is the river?
Oh, Lord.
Deep enough for the
Okay.
hammer.
You cannot walk across it. You cannot drive across it.
Me, Pacho, I have a question.
Hmm?
Is the mountain impassable?
Okay, we'll say no.
okay, and Efua Nsia, did you ask your question?
No, I didn't. So the dark area that is encircling the whole area, is that road as well? Because I see the roads next to the river, but then where does that end?
So it ends where it ends. So the one where you see that the road is out, it ends at the border. This one here, it ends at the border. So the dark line is the border of the country, but you can assume that that is also navigable. So here the road intersects with the border, and here the road intersects with the border.
Okay, so if all questions are answered, I'm going to place you automatically into a breakout room. Your breakout room will give you a 1-minute countdown to let you know when you have a minute left. And then the breakout room will end automatically and send you back to the main room.
So in this group, who do we have here?
Yeah, Kehembe.
Yes. Hi. You got to turn your mics off, everybody, so you can communicate. Go ahead and unmute, please. This is a group project. Kwesi, I see your mind tinkering with your mic off. You got to work.
I'm about to jump to another room, so, you know. But that's fine. I mean, I can work in this room. It's no problem.
Don't abandon us.
So we got 4 breakout rooms, so that's cool.
Hey, Palcho, where's the map?
Let me see if I can share. Yeah, I can share my screen. Let me do that.
So you have to go back to each of the rooms then to share.
Mm-hmm.
Okay.
Oh, okay.
So.
Can you see it? Let me put it on slideshow.
Yeah.
You can see it.
Okay.
Oh. We're here, right?
So the first thing we have to do is decide what is our initial task.
Well, your task is to get medical and food supplies to all 4 areas.
Yeah, but what I'm saying is now the approach to that. What's the first thing we have to do in order to actually accomplish that?
Yes, you have to decide who's on your team.
Right. So how many people?
You have up to 50 people.
Right.
You need a medic. Do you need a doctor, a nurse, a teacher, do you need a priest? Who do you need?
And we're hitting all the areas, right?
I'm sorry?
We're supposed to deliver to all the areas.
Yes. And I don't know if I said this before, it should have come up, maybe it did not, but assume that English is not widely spoken.
Okay.
As you move out of the center. They speak Twi more so. And assume that all of the indigenous and traditional folks is based on the Akom belief system and people.
Okay. Are you allowed to go outside the borders?
Yes.
No.
I mean, come on. If you got to go from one country to get to the next one, what's the problem?
Well, it's all one country, but the issue is sometimes you're not able to cross through either a mountain area or a river area on that side, in that part of the country, but maybe go into another part of the country. But that's, you know how they have those little guard men sitting at the borders.
So my thing is, we already got enough roadblocks. We got a beat up Hummer, and we ain't got no money. So I'm like, let's make some good assumptions that we can do it. No one said we can't.
I did not say the Hummer was beat up.
Okay, he said it ain't fancy, so.
The Hummer is in mint condition.
It's got to be filled with gas. To
assume that you have gas.
Yeah.
All of the supplies that you need that are listed here.
There's
I didn't list gas, but assume that the Hummer is gas.
Right. So there'll be some areas that won't be approachable by a vehicle, that would have to carry things.
Okay.
We have that because all of the food is in this Hummer, I assume, and or in these backpacks, and or people are carrying them. And supplies and food for ourselves would be in there as well, medical supplies as well in the backpack. Water, we got to have our own supplies to move around.
Assume you have water.
Right.
Mm-hmm.
Okay.
Okay, so can I leave? I'm gonna go and join another group.
Uh-oh.
Are you guys good?
So we need to elect some leadership. So who's the leader in this room?
Okay, bye.
Somebody else needs to talk. Show yourself.
So this is Abimbola. Oh, the map just left. Okay. What I was going to suggest, but the map is gone, but we have to send some people to the left because and then there was the bridge, so we could have some people go down. I can't see the map. I should have taken a picture.
Let's see. So there's a bridge.
Yeah, there was a bridge.
And
so over the bridge, we can get some supplies over.
But you said the bridge had a hot spot, a hot zone.
Yeah. So everybody's not going to go in the same direction. We have to divide
it up.
Yeah, we have to divide them up.
Right.
We have 50 people.
What if we divided the 50 people into 4 groups of 12 or two groups of 13 and 2 of 12? I think the math is right.
Mm-hmm.
And we can identify whatever the skills are needed. For example, if we got to go across the river, we may have people in that group that can swim well.
Mm-hmm.
And if we got to go through the mountains, there may be some people, considering that this is where these people live, they probably know how to mitigate or navigate through the mountains. I'm just making a suggestion.
Right.
The reason I'm not on screen, I just want to say this, and greetings, Mama Kahembe.
Greetings.
Abimbola, CB, right?
Yeah, okay.
Greetings.
I'm kind of working, so I'm working while I'm participating.
Uh-oh. So we got a handicap. Is that what you're saying?
No, I'm gonna do my best to contribute.
Okay.
At the same time, I can multitask a little bit.
Good. So one of the things is there's certain kinds of food that'll be distributed to certain places based on need. We know that the Muslim areas would not take any pig. So whoever is in the group that happens to be Muslim would be the ones willing to carry that.
4, 4, 8, 12, 13, 14, 15, 16. So I only got 20 people so far, so we got 30 more people we can get.
Well, people gotta work.
who's going to tell folk what to do? And then the people got to do it.
And how long will we spend in each area? Dropping
We
off
got
supplies.
2 weeks, right? And it's 4 areas. So I guess a half a week.
Okay.
Approximately a half a week in every area.
3 days, three and a half days.
But we need travel time, remember?
Yeah. So,
Okay.
so we doing stop, drop, and roll?
Now, is it possible to have some of the locals to meet us to get to some of the supplies? Or we don't trust that?
Well, how about you have that group over there, the everybody group that's very close to our camp that is easy to get to. They're easy to get to, and I was wondering if we want to use some of those people to help us.
Yep, to get the supplies there.
And they might know some secret pathways to get us through some places.
And they're from the country, so they may be able to do some things that we couldn't do coming from a white organization in America.
Yeah, I'm sure there's a lot of little motorcycles that we could jump on. And get.
True that.
So the other people who aren't saying anything, what's on your brain? Because we need everybody to figure this out.
What's in the supply bags? What's in the supply bags?
You got
the backpacks.
Whatever
Food
you
and supplies.
need, you can
Food
design.
and supplies.
So we need actually 4 guards.
May Paucho,
We need 4 guides.
can you
Go
all
ahead.
hear me?
We can hear you.
Okay, this is Efua Nsia. I put the map up and I wanted to leave it up for a little bit.
Where is it?
It's, if you're looking at your computer screen, I'm sharing it.
Yes, I can see it.
Yeah, okay. So I'm gonna leave though and go to another group to make sure everyone's okay.
We have no money.
Because there's no place.
What if we just get, what if we don't worry about the Hummer, we could buy back a Jeep?
Some Jeep.
That could have.
That was the Cho-Cho. We said we were gonna buy a boat and a Cho-Cho.
Okay, but if we, okay, a boat and a Cho-Cho.
Or a Jeep, like you said.
And then we could buy a Jeep, which is smaller, but it's still gonna give you the 4-wheel drive to get you over bad roads and, you know, through mud or whatever.
No, I think you're watching too much TV.
I'm not watching TV. This is what happens.
We got
in Ghana, they travel everywhere by Cho-Cho.
Yeah, I get it,
but it doesn't give you the drive through mud. You can't get a Cho-Cho through mud because.
So what about a Jeep?
It does. A Jeep has 4-wheel drive.
Okay,
that's what you need.
So why not 2 Jeeps instead of a Cho-Cho?
Okay.
Yeah.
Scratch the Cho-Cho and get a Jeep.
So can you get a Jeep and a boat from selling the Hummer?
I think so.
Yeah, if you
can get a Jeep and
if you
Is somebody documenting, somebody writing this down?
Isn't that you?
No, because I said I don't want to present. I don't like talking.
A Hummer is $70,000. I don't even know if that's the latest one.
No, he said it's not. She said it's not the latest one. So it was the original cheaper one. Couldn't have been 70,000. The one we had.
No, it's not the cheap ones. It's the Army one. She said the Army one.
Oh, that might be
more.
That probably do cost more.
Yeah, because they overprice everything. But still, we're spending a lot of time on trying to get the transportation and not the strategy.
Okay, let's divide the people into 4 groups.
Okay.
So basically 12 each.
Yeah.
Okay. So we're selling the Hummer, we're buying a boat and a Jeep, right?
Yeah.
You send the boat to 2 areas, the Muslim and traditionalist area, and what's the other area?
Could you put that up again, the picture of the...
Everybody area is 3 and
Christians and traditionalists are in area 4.
Okay, but you see, we're in the middle. We can walk to the everybody area.
Yep, or drive.
Or drive. Yeah, that's a trek.
Right.
So
But
you
the
only
Christians and
that
traditionalists
one
will be
area
hard
to get to the
to.
Muslims and the traditionalists at the bottom.
We can drive to the, we have to walk to the, across the mountains.
Okay.
To the Christian. That's a foot trip. The river, we can get
Who's
to
up there?
the
Muslims?
Well, wait a minute.
Oh,
You
Christians.
don't necessarily have to go through the mountains. You could go around the border.
But it doesn't.
That's what I was saying.
I thought you said that earlier.
You don't have to
Yeah.
go through the mountains.
So if they drive, then they can drive from to everybody up to the mountains, pass on the road on the side, and then to the Christians, and then take the boat to get to the
That to the
Muslims
south, yeah.
and traditionalists.
Okay, how about what did they break us up?
Time is up, probably.
Yeah, time is up. I didn't see it.
Oh, because I was trying to figure out how we were going to divide up the food, and I think we did talk about that a little bit. You can't take the pig to the Muslims, so they have to get the goat or the cow, and then the millet and the rice and the sorghum.
On the boat.
I don't know.
I don't have no boat.
Pig has to go.
Oh,
to
gosh.
If which,
everybody.
but remember, we only have 2 weeks, and there's only one vehicle. If we don't get a boat, it's 2 weeks and one vehicle. Can we get to all
Christians
those
are
places?
gonna want- Yeah, we got 54 seconds. The Christians, the traditionalists may not want the pig, but the Christians are gonna want the pigs. So we gotta take that into consideration too.
You know, when there's a representative in each group, so they're going to know what the groups need. We just need to make sure we have our reps. You know, they're going to go and meet with them.
Right, but I think we also need to be clear that even though we have what they need, do they want what we're getting? Do they want what we are offering? I mean, because we don't know if they've had previous experience with other organizations that have given them things and then turned around and required them to give something else.
Well, that can be part of the conversation, that our particular people. So again, let's go back. We got 4 groups. We've got 4 teams. Each team is going to have health, guide, protection, food, people who are carrying the different goods.
Mapacho, yes. So I see you all are quite busy in that group. Very lively discussion. We are back into the main room.
Okay.
I just want to hear some of the strategy.
So
you all were really, going in depth. So I want to hear a little bit of that. But we're gonna now turn it back to Okomfo Nsia.
So I love this exercise. I love to hear people's creativity, what they come up with. I got a chance to go into all the groups. Some of y'all making up stuff. Y'all done bought boats, and somebody said that the Hummer was old and rusty. So it's just really interesting, and I'm very anxious to hear what you all came up with. So can we start with group 1? Did you select someone to report back?
So you can unmute yourself and share out.
Can you tell the people who were in each group? Because I don't know if anybody paid attention to what their group was.
Okay. So let me see how I can do that. So breakout room 1 was Akosua, Amaduma Bediako, Amo Aperi, Efua Bentum, Nana Kuya Ajimen, Nana Esidina Zulu, Okomfo Efua Duku, Rukaya Afiba Nsia, V40 ThinQ, and Ya Nsia of Perry Phillips.
Okay, so I recorded, so I'll report. You asked us, who do we need on our team?
Mm-hmm.
We have strategists. The strategists how to get to all of the different areas and not offend anybody's culture or religious practices.
Mm-hmm.
We need communicators or ambassadors
that are familiar with the different practices, you know, the Christians, the Muslims, and the traditionalists. We need military or a security team to help us to get through the hot zone. We need carpenters to make sure the bridge is good if we have to use the bridge to build boats to get across the river. We need engineers to help design those boats. We need drivers for the Hummer. We need at least a few drivers so they could alternate. And we need medical people.
What kind of medical people?
People that are familiar with the organisms in this particular area, people that can administer first aid if any of us get sick.
Mm-hmm.
We need, you know, traditional medical people. We need people that can give us self-care advice if we need that, first aid advice if we need that. If we go in there and somebody's having babies and they need help, we need some midwives and people that can support along the way.
Okay. Thank you. Group 2?
Group 2 is Abimelech Wali, Efua Scott, Akuya Johnson, Kafense Chike, Kofe Fojo Tyus, Okomfo Kwabena 9, Serwa Anoche, and Kahimbe Ackelberger.
We did not appoint a point person. So, and we didn't finish.
Well, let me suggest the most senior person just speak. How about that? That'll take care of it.
Or a summary of what you all talked about.
I like group 1. First of all, they said all the things we needed to say. We were really busy trying to look at the logistics of how to move throughout, dividing up the group into at least four groups out of the 50, and then see who can best facilitate movement in the various regions based on the climate and all of the areas, other kinds of things that create a problem or a challenge. We needed those who knew the language and the culture and could represent the people that were there, understanding there would be some Muslims who would not be carrying certain items and other people who would be needing certain food items. And that was that's about as far as we got. We really needed to look at the picture to see which would be the best routes and how we could also possibly hand off some of the food, assign some of the things to people who would be coming closer to us to meet us to get it if we couldn't get to those places. That means having some point people from the various areas be able to come to each of the team areas if there was some problem. That was pretty much where we got. Another 2 weeks, we would have had a strategy.
Thank you. Group 3?
Breakup room 3 includes Shayla BG, Okomfo Efua Radford, Numo Tigre Kwabena, Nana Aba NCO Perry, Mami Yaya, Lucina, Kwajo Sarpong, Amaduma Bediako, Akosua Bakeman Giaboa, and a phone number ending in 9144.
Okay. I took the notes. This is Mami Yaya. But we didn't appoint an actual spokesperson, but I will say it and the rest of the team can jump in. So we did not get to finish either. We did settle on the team that we needed, similar to group 1, that we would need guards like security, people to help feed us, people to, we would need the guides, the cultural folks that were familiar with the land, as well as practitioners, doctors, nurses to help take care of us or anything that we encounter. We started exploring breaking up into teams because there was a group close to the camp. So we could send people there on backpacks. We could use the Hummer to go up to the mountains and navigate around the outskirts to get on that main road. And that was as far as we got. We knew that we couldn't take the pig to the Muslims, so we started exploring that a little bit, and then we were put back into the main chat.
Paucho?
Yeah.
If I can add, this is Lucina, if I can add, we also started getting into a talk about, and that's where we came in back into the main group, the discussion of engaging with the people with regard to their needs. So not just coming from that paternalistic perspective of this is what we have for y'all, here, take this, what a good job we did, pat ourselves on the back, but, you know, engaging through, of course, the representatives of the people in those areas and those who are language enabled and who are part of the cultural community of those specific areas who came with us, having them to facilitate actual discussion and dialogue about what's actually needed on the ground when we get there. So that too is a part of our interest, because, you know, this is a lot to load up and to move. And if you're moving things that you don't need, for example, the consideration of not taking the pigs to the Muslims, you know, we don't have to load everything up, or some of those supplies can go to other people, you know, or we can use them at our camp if nobody needs them, you know, but whatever it is. So that also is part of the discussion.
Excellent.
Okay, and breakout room. Oh, I'm sorry, go ahead.
No, go ahead.
Okay, breakout room is everyone who's left, but I will call the names just for everyone to be clear. That is Afiba Anum Amoa, Ama Willock, Ama Calhoun, Dana Ama Surwa, Kwesi Amoa, Lenora Walters, Nana Efua Nsia Santiwa, Natalie Aguara, Okomfo Bachewa, and Okomfo Efua Nsia.
Auntie Amabadu, you're the eldest. Would you like to lead? But before she leads, before she does, I have a joke. So okay. The joke is, we were the team who sold the Hummer, which was worth $70,000.
That's right. Okay.
So that we could buy a smaller vehicle, a Jeep, and a boat, because we wanted to get the items to them fast.
Exactly. And that was our strategy for the most of the conversation. It was about logistics. We were going to sell the Hummer. That was the first thing that Okomfo Efua suggested. So then we sell the Hummer, we buy a boat, and at first we were going to buy a trocho, but then we said we need something with 4-wheel drive to go over the mountains or to get into areas that might be muddy or whatever. So then we also took into consideration the whole thing about we can't take the pig where the Muslims are. You know, we knew we had 50 people. We knew we had backpacks, so some were going to be going on foot. Can we get them through that pass in the mountains? That's what we want to do. We want to get up there to the Christians and traditionalists, so they can backpack through that part. But if we didn't get to the point where we were dividing up all of the materials and this and that, but we had kind of structured out the logistics of how we were going to get to the 4 areas. And, you know, we had to change out our transportation to meet that goal.
We did also talk about not taking pork to the Muslims, right? And we, like many of the other teams, we didn't finish. We needed more time. We were like really in it. This was a lot of fun. I want to tell you, it was serious, but it was a lot of fun. So thank you for that activity.
Sure. So this was my first global health class that I took in my MPH program. This was a task given to us, and it was a lot of fun in this class, and we took it very seriously. And it just really shows you all of the considerations that you have to take into account. And I was in this class mostly with physicians, some surgeons, and you know, they don't listen. They don't listen. They want to focus on the treatment. And our group got dinged. You know, my bachelor's is in anthropology, so of course I have a totally different take on the situation. And we got dinged. We were basically judged by a group of professors. We had a linguist, we had an anthropologist, a physician, a global health person, and a lawyer sitting on this panel to review us. And we got dinged because we didn't take, well, the physicians in my group voted to not take into account the culture of the people, the political situation going on. They didn't think about, oh, we can't just go and start talking to people. We have to actually go to their leader and talk to them. It's some places, like when I was in Mali, you can't go ask a woman to participate in a clinical trial. She has to ask her husband. She literally cannot sign her name and say, I'm participating in this, if her husband has not said so. And before we even go to an individual family and talk to them, we had to talk to, I forgot the term that is used, the religious leader for that particular area. Do we have permission to come into your community and talk to your folks, you know, about this clinical trial, about this intervention? And I like the creativity that you showed. No one group thought of it the same way. And it shows that you need a multidisciplinary team together so that you don't have everyone thinking alike. You need people with different experiences, different skill sets to get you through. Like someone said, we need engineers because y'all gonna fix the bridge. Y'all gonna fix the bridge as you go along. You know, so you thought about, like, who do you need with you to make that happen? And I think the most important thing that was brought up was Lucina making the comment about doing a needs assessment. It essentially is what she was saying. What do y'all need? Instead of us coming telling you, well, I've been here and I think I have observed, you know, the situation, so I'm just going to go and tell you this is what we're going to do. It's no, you humble yourself and say, what is it that you need? And there are many different ways to do that, but that question always needs to be asked so that whatever it is that you're trying to do actually fits with the needs of the people and not what you want to do. So I'm hoping everyone enjoyed that. It was not meant for you to get finished in 15 minutes. We had, I think, a month to do this project. It was much more, you know, detailed and fleshed out, but it gets you thinking. It gets you thinking about the geographical landscape you have to take into consideration, the political landscape, the cultural and religious landscape that you all have to account for if you're planning to do some type of intervention. So with that, we'll move on. So I want to talk about global health today. And I have some notes on this, but I tried to send them to myself on my iPad and it didn't show up, so I'm gonna do the best that I can. So this woman here just settled, she's a US citizen, and she just, I'm sorry?
Share your screen.
Oh, I'm sorry. I thought I was sharing. One moment. Is it sharing?
Yes. Yes.
Okay. Why can't I?
Have your notes. So you want to have the slideshow view?
Yeah. Hold on one second. It's too many things going on over here. Okay. Too many things open. All right. You're seeing it?
Yeah, that's good.
Okay. Perfect. So this young woman graduated from high school somewhere in Virginia. And apparently she had been on some previous trips to Africa. So she started an NGO out of high school around, I think they said about 10 years later, but no other training, and moves to Uganda and opens up this treatment clinic. And she is responsible for the deaths of over 105 children in Uganda. She was essentially practicing medicine without a license, with a high school education. But this went on for almost a decade, from my understanding. She was finally sued by some parents that lost children in Uganda and an attorney over there. And she just reached a settlement. This was just in the news. I put this in here at the last minute. I just read it, I think, yesterday morning. It came up in the news. She's back here in the US. She is not in jail. But she has agreed to never go back to Uganda and to never, operate this NGO. It's now defunct. And she's settled for, I think, $9,000 per child. This is just an FYI when global health goes bad, when white savior syndrome is operating in full effect. 105 children. And Paul Farmer, he's a famous global health professor at Harvard, and he talked about not reproducing colonial systems, which is still a major problem. And I showed the slide of this girl because I believe that she was able, I don't have any proof, but I personally believe that she was able, with a high school diploma, to go into Africa and do what she did because of the colonial mindset that she has, but also that some of our brothers and sisters tend to have as well. And to have the audacity to do so. Like, I can't imagine, even at this stage of my life, where I'm not a clinical professional, but I've been trained to do certain things, like to be a phlebotomist and to do other things while I was a research assistant. I'm sure I had more experience than she did, but can you imagine yourselves right now going into another country and performing medical treatments? And this was, and I'm sorry, I forgot to note, this was on severely ill children who were severely malnutritioned. And in the article, it stated that just the inputting a IV incorrectly, the children were so malnourished that it could cause a heart attack in the child, which that's how one of the children died, because if you don't have the sodium levels correct in the IV solution. And so that a trained medical doctor or nurse needed to calculate, to the nth detail of what to put in. This woman was introducing IVs and doing other serious medical treatments on these children.
Okomfo Nsia, a quick question was asked. How was she allowed to do this? Was there a vetting process, or is there a vetting process, or can you speak to that?
So this is an issue on the continent. There are NGOs, large and small, known and unknown. Depending on the country, they're over there free willy. It's a free-for-all, and it's scary. And some countries have gotten more of a hold on who's coming in and doing what in their countries, but often they don't know. And I'll give you an example. So again, this same project that I was working on in 2018 with Gates, through the University of Maryland in Baltimore, there was some back and forth between Gates and UMB about how this trial should be set up. So the Gates Foundation said, well, the drug has been tried already. We don't need to do an experimental trial with a control group. Everyone can just get the drug instead of doing this control trial, case control trial. And so the PI from UMB was like, nope, it needs to be case controlled. And what that means, and what that meant for this, and let me back up one more time with this. So to finalize the study design, the Gates Foundation flew all of these maternal and neonatal health experts to Seattle from around the world, literally from around the world, for a one-day, 8-hour meeting. And I was there in this meeting. And there was one other Black person there, the Minister of Health for Mali, and everyone else in the room was not from the continent of Africa. So you had one African American and the Minister of Health for Mali making a decision about the study design for pregnant women and newborns in Mali. And what was decided was that it would be a case control trial, and they would have 4 groups. The 4 groups were: 1, the pregnant mother received the treatment and the baby would receive the treatment right after delivery. That's group 1. Group 2 was the mother would receive it and the baby wouldn't. Group 3 was the mother wouldn't receive it and the baby would. And then the last group, the true control, is that neither the mother nor the baby would receive the treatment. And this is typically how, you know, you do a truly experimental trial. But is it applicable in an area with such a high maternal and infant mortality rate on a drug that has been shown to lessen the morbidity and mortality of mothers and newborns? Especially if it's been tried, it's been written about 7 or 8 other times. Is it appropriate to do that? And who makes that decision? So while we're in Mali doing the needs assessment that Lucina talked about, well, it was more so a capacity assessment. Another team arrives from, I forgot what European country, that we didn't know about. The Minister of Health in Mali did not know about, funded by the Gates Foundation as well, with close to $50 million to do an MDA, or mass drug administration, of the same drug that we were there to do the clinical trial for in another part of Mali.
Mipacho.
Yes.
You know what this sounds like to me? I don't remember all the minute details, but there was talk of testing a COVID drug on the continent, and then there was huge outcry and uproar. And then it dropped out of the news, so I don't know if they changed their minds, but it was the same type of issue that these Europeans had gone over there and decided, we'll test the new COVID drug out on these Africans, because we can do that. They just were so comfortable that they just said it out loud and said it in public, and the news got hold of it.
And unfortunately, even though there are all kinds of international conventions and HIPAA training and human subjects research training, and you know, all of this that goes on, and you learn the history of these past atrocities that have happened in the US and around the world, and you know, all of these controls are supposed to be in place. Unfortunately, they're not always enforced, and the continent is my personal feeling is like the world's guinea pig still.
Yeah, me Pacho, Amadama. I think there was something with milk for babies that was tried also on the continent.
That was, are you talking about Nestle?
Nestle's years ago, because they were making people believe that the formula was just as good as breast milk. And they realized babies were dying because, one, the women were stretching the formula with too much water, and a lot of times the water was contaminated. So, you know, and then Nestle's goes in there, they knew what they were doing.
Yeah, it was basically like introducing crack. So they went into these communities and said, you know, here, try our product for free. You know, this has all the nutrition and more that your baby needs. It's better than your breast milk. They're going to grow big, healthy, and strong. You can hear it's free. Take it. And then it was, well, now you got to pay for it. And so the women couldn't afford it. So like Sister was just saying, they start thinning it, adding more water to it. And the babies weren't getting the nutrition that they needed. And it was a disaster. These babies died. Nestle first tried to say, oh, that's not what happened. And, you know, of course they tried to cover it up, and there was a international outcry. And they had to walk back what they said. And
there's a movie about that called Graves at Zimbabwe.
Mm-hmm. I actually had the opportunity to go to Nestle headquarters in Switzerland and They have a wall dedicated to the incident, but they still have whitewashed it. They have still kind of absolved themselves from the responsibility, and they've totally spun it into where they did this campaign to improve women's health. It's probably one of the more horrible things that I've learned about in recent global health history.
They started sending cigarettes to young children in different parts of the world when they realized that people in America were going to stop smoking so much. I saw a 5-year-old in some part of the world smoking because they were pushing cigarettes all over the place.
And that is actually a part of some of the US trade agreements that we have with other countries, is that if you do trade with us, we get to dump our cigarettes. That's actually written into trade agreements.
So, Okomfo Nsia, what happened with the case where you all were doing an experimental experiment or a trial, and then you have another group coming, just giving out the medication in another part of the country? What was the outcome of that?
So I don't work there anymore. So I don't know. That whole situation was it was scary for many reasons. I felt like I was in a movie. Like, this was stuff that happens in, I don't know, one of them crime movies or whatever, where there's some, scandal, but it's still going on. I mean, this is like a long-term project. So when I was there, they weren't even set to implement until I think this year, or maybe, this year. So where they are now with the distribution of the drug, I have no idea. But it was set so that the folks doing the MDA were in another part of the country. But I think it's still going to cause issues, because you have in one area, and it's not that far, folks can navigate between the two areas and they talk. And so you have a drug being given out for sure with an MDA, and then you have a drug that you might get and you don't know if you're getting. So if I'm a pregnant woman in Mali who's malnourished, my baby is malnourished, there's all kinds of other issues going on, I'm going to go where I know I can get the drug. I'm going to try, I'm going to do what I can to get that drug, to know for sure. So you have all kinds of risk involved. Folks could be over medicated. You have, I think now you're going to have maybe some reliability issues. Did people actually take the drug or not? Did they go elsewhere to get the drug? I think it just confounds all kinds of problems that are already present in an area where you have a very high maternal infant mortality rate. Like, I mean, high, one of the highest in the world.
As a follow-up into that, would you say then that, because you mentioned they came in, that both programs funded by Gates. So in terms of the earlier question, in terms of how people are able to kind of come in and do what they want, would you say that money speaks loudly to allow any person to kind of come in and do as they wish?
Of course it does. But at what point is that going to stop? And we could also talk about the sex trafficking and the sexual tourism that goes on in Africa with grown men purposefully coming to Africa to have sex with children, because they're basically saying, I'll give you some food if you do X, Y, and Z. And these kids are being raped. And folks know they can do it, and they intentionally go. There was a write-up about this Peace Corps volunteer recently that I think he's in jail at this point, that did this somewhere in East Africa. I can't remember the country. So yeah, of course money talks. And when people are in severely desperate situations where it's like, I gotta choose between eating and you have the food, then I'm gonna do what you say. So it gets back to, basically, it's still colonial control. It's still colonial masters going in and dictating what happens in these countries, formally or informally. So the sexual tourism is informal, but then you have situations like I was speaking with the ambassador for the African Union, well, the former ambassador for the African Union. I was so excited. I had this idea, you know, we're gonna go, we're gonna do this, we're gonna do that. And she's like, it's not gonna happen. She's like, you have to understand, these NGOs are determining political outcomes. They're influencing elections. Don't nobody in Africa elect nobody except for who the NGOs want elected. So the flow of money from, you know, these provocateurs, these colonizers who still want control is a major problem. It is a very serious issue that I feel is like, I don't know if it's something that is even manageable or how you start to fix that. When you have people starving to death, when you have corruption, and all of that just kind of blends all together, and you have mayhem. You have children exploited. You have medical procedures and testing going out that shouldn't be happening. That could never happen here in the U.S.
Okay, we have a question hand
raised.
And we'll let you go back to your presentation.
Sure.
So Rukaya Efua Nsia has a question, and after that, you can continue.
Okay.
I'm sorry, it wasn't really a question. I wanted to speak to the fact, similarly to what happens here with segregation, and the fact that once we integrated with others, there was a time when we chose their doctors, their lawyers, because we thought that it was better. There's a similar behavior in a lot of Africa, a lot of South America, a lot of the world, really, that trust the institutionalized healthcare versus their traditional healing. And so I felt like I think of something you were saying just now is what jargoned it in me, how in Sierra Leone there were so many women who were saving up their monies during their whole birth just so that they could have the birth in the hospital. And then the hospital had a doctor who literally was, I think it was a prison term. They were sent to that area to deliver births, and she was literally cutting women open, performing cesarean sections over and over unnecessarily. And these women are trying to be in the hospital to get that care, but instead they're being butchered. And I mean, it's a similar mindset that we've had here.
Yeah.
Even now, after what happened with George Floyd, a lot of us are trying to spend money with our own, but then there's this concept of, you go to Black business, either someone wants a discount, or the expectation is that we're not going to get the right what we're paying for. So it's global in that it's definitely something. I mean, so much of what you said happens in Africa, and it happens here as well. I know that my mom received the BCG vaccination. When you speak to white folks here, they say, oh, no one gets a BCG vaccination here. A lot of the trials and research that's been done in Africa have also been done to create problems in our communities here in America. So it's just, I see Paul Farmer's, I'm a fan of him. I read his books. One of the books, Mountains Beyond Mountains, it speaks to the Haitian proverb, mountains beyond mountains. It's like one problem, we correct one thing, and then there's another thing. It's just another thing, and then it's another thing, and it's like, okay, how do we get to the healing? How do we get to the support and the true decolonization? Like that's the ultimate goal that it's so difficult to get beyond.
Mm-hmm.
We do that. We do that through our spiritual beliefs. We do that by training our children from the very beginning, by speaking to them and having these conversations with them. A lot of times we have these conversations and it stays in one place, and we don't think our kids need to know some of these things. We don't have to give them all the gory details, but we need to train them how to use their money, who to spend their money with. We have to retrain their minds so it doesn't repeat. And then that'll duplicate when they have their children and those children have children. So we have to take that charge to do the work for all the healing. That's why Akom Kese is here as well. Even when that sister was talking about mental health and DNA memory, I'm not sure if I'm using the right terms because that's not my area, but we have,
epigenetics.
Thank you. We have, right, we can change it. We just have to believe that we can change it.
Okay, thank you.
Nsia, there are 2 questions, but I'm gonna let you finish your presentation and then we'll come back to those who have a question and a hand raised.
Okay, and another thing I wanted to talk about was some of the top causes of death. And I picked Ghana because that's where we associate mostly with. And then I picked, of course, our ethnic group here in the US. And these are in order of, with the first disease listed is the #1 killer for each group. And I highlighted where the similarities are on this list. So I put this slide up here because even though, of course, we are not suffering from malaria in the United States, we did have malaria in the US in the South up until the 1950s. That's another story. We do have some of the similar, some similar health concerns between our 2 groups. And on this top 10 list, we have 6 in common that are both on our top 10. And I would include for African Americans, HIV, influenza, and pneumonia as infectious disease, along with Ghana's tuberculosis, HIV, AIDS, and diarrheal diseases. Those are all usually from some sort of vector or parasite. I also linked unintentional injury to road injuries because usually unintentional are like accidents and things like that. But you can see HIV, AIDS, stroke, heart disease, lower respiratory disease. Those are usually pathogenic as well. And diabetes are diseases that African Americans are suffering here in the US and also are being suffered in Ghana in very high numbers. And speaking of health disparities, I wanted to show this, and I'm going to click on this link in a minute, but we see health outcomes and where the US ranks for disease, but that is not usually disaggregated. It's usually everybody. But when you look at us, if we were a nation, if we were a country, and where we would be for health outcomes, are you still seeing my screen?
Yes.
Okay, so for maternal mortality,
no, we can't see it. We can't see it.
Okay, give me 1 second. I'm gonna do it again. I think I have to share a new screen.
Okay. I can see it. You can see it. I can see it.
Oh.
So I can see it now.
Okay. So the United States, there was no. Huh?
Can other people see it? Because I mean, I'm seeing it. Can other people see it?
Yes, we see it.
Yes. Okay.
Yes. No, I can't find. Okay, there we are. So the U.S. This is for maternal mortality. So usually maternal mortality is measured in the number of deaths per 100,000 women. So this is the lowest amount, and as you go up, it gets higher. So the U.S. overall ranks here, 129 with 19 deaths per 100,000 women. And that includes all races. But the maternal mortality rate for Black women is 40. So it's more than twice than everyone else. If you break it down by race, our maternal mortality rate is 3 times that of white women. So if we were a country, we would be up here. We wouldn't even be in the United States. We're starting to get into levels of low and middle income countries. with our maternal mortality rate up here. We're nowhere near where the rest of the United States is down here with maternal health outcomes. Now, of course, it's not as high as some of the African countries. They're up here with they're in the hundreds, sometimes thousands per 100,000 deaths for their maternal mortality rate. Ghana, I believe theirs has gone down over the years, and it is, I think, in the 300s. I think like 308. Yeah, right here, 308.
So let's ask if you can go down to the bottom to see who's number one.
Sure. It's not the U.S., believe it or not. Number one, or the lowest maternal mortality rate, you mean?
Yes.
Yes. So it's this group down here, these folks.
So Okomfo Efua Nsia, all of this has been very informative, very downing at this point in time, because there's a lot of stuff on here that we can't do anything about right at this moment. I'm sure that your intent in terms of educating us was to also share with us. You said something about the role of the African diaspora. What were you bringing that you want us to focus on that we can or should be doing about this?
Okay,
you know,
I'm gonna get there.
Might be it, whatever it is, but it has to be more than just the fact that these are all the things that are going on that are wrong. We know there's a whole lot of things going on that are not for us. But what I'm sure that's not what's the purpose of your discussion today. So I'm asking you, because it says outcomes, what the role of the African diaspora, how the mobilizing the Akom community for, how do you see that mobilizing the African community? What are you bringing that people can take away where they feel that they have been empowered to do something?
So my question is, and it's on the next slide, is given everything that I have shared, and the point of this was to first provide a baseline education about global health, because I don't know everyone's background and what they know and what they don't know. So for me to be comfortable in first asking this question was to inform the community about what is going on, what has happened, what my personal experiences have been in global health. And I didn't intend for it to be, all bad, but there are some very dire circumstances. Yes, there are some very great things that have come out of global health as well. For example, polio is near eradicated. But I can't help from working in this field and the things that I read in the news, like I just showed you the article that came up just yesterday. I can't help but see the glaring issues that exist in this field and how they impact the continent. This is also triggered by my graduation last year in Ghana and me observing some of the health issues that were there. So I shared all of that to get us to this point. What role do we play in improving global health and development on the continent, specifically in Ghana? And first of all, do you feel that we have a role in health and development in Africa and in the diaspora? And if you think we do, what is that role? How do we mobilize and operationalize our communities to assist here? And that was the reason for me showing the health disparities that we have going on here, as well as what's going on in Ghana. And then more importantly, how do we fund it? And so I shared information about the funding mechanisms, about how global health is funded, how these organizations set the agenda and then divvy up the money amongst themselves. How can we come together, fundraise? How do we do it? So I don't have all the answers. And so I came here to tell you what I know, to tell you what is currently going on, and then ask you, what role is it, given that we know we have a very intimate relationship with traditional communities in Ghana. We have a lot. I learned yesterday we have physicians and nurse practitioners and nurses and other medical professionals. We have educators. We have community activists. We have all kinds of folks right here in our community. And to my knowledge, there has not been a galvanizing of our shrine houses, of our practitioners, of our adherents to address this issue that I think is of paramount importance. So that is my question for this group. How do we do this? And we're actually going to break out again into our final breakout. And I want this discussion to happen within your group, and then we'll reconvene and hopefully share our answers and build some consensus around what and how we should be doing this. And then from there, let this be our starting point for doing something about these issues going forward.
Before we go into breakout rooms, Nsia, there were two questions. So I'm gonna ask Kwadwo Sarpong if he can please unmute himself and ask his question. And then Valerie Kahembe, I know you put your question in the chat, but if you like, you can unmute yourself once Kwadwo is finished to ask your question. So first, Kwadwo Sarpong.
Blessings. This is Kwadwo, Okomfo Kwadwo Sarpong. It's a beautiful thing for us to all come together and have these discussions. I kind of follow in the same spirit of the person that just spoke, and I think that what's extremely important, that when we come together, that we are identifying solutions for these problems that we have identified in the continent. And Medasi for the work that you are doing in the health field. I'm an engineer. So what my thing has always been about is, okay, we identify the challenges, as you have done very well, and then we create solutions for addressing those challenges. So, and so a lot of what I'm about to say is mute, because you facilitated exactly what I'm looking for, or what I'm concentrating on. Mm-hmm. So there are, and your activity also catalyzed that activity. So thank you for what you're doing. Thank you for what you're doing. And one thing that really stands out to me is every time we go to the continent, we need to be, talking to those people who are in leadership there and asking that question that came out from the activity. What do you need? That's the first question we need to ask. And then when we come back together, we need to communicate, the people need this. And then we need to talk amongst each other about how we're going to provide, or how we're going to assist them in accessing whatever that is. So that's all I have to say.
Thank you.
I'm Medasi.
Okay. Kahembe, if you can unmute yourself and ask your question.
Yebo, again, I say Medasi as well. Thank you very much for providing this critical information for us. Mainly, so, and I think when I asked my question, it was before some other things came up, and I think it almost speaks to, the answer is our role. My question was, is there any international oversight over any of this? Because you have people who may mean well, but then you have other people who have some underlying reasons why they want to do this. They either want to annihilate a people or do whatever it is. So is there any international oversight? And I'm really almost at the point, once you got further into the discussion, to ignore it if there is any, and for us to take out our arms and be a call to arms and be the ones to move into it once we decide how we as a group of Okomfo and Akom people and people of African descent here decide that we can take charge of this, as we did in our villages here, as we've taken care of our own people here, particularly in the South during the times of enslavement and post-enslavement. So I'm almost seeing that what you've come up with is ask us the question. And once we take charge of it, then we're not involved with anybody else who's trying to have their own personal agenda.
Exactly.
Okay, great.
And so I went all around the mulberry bush. And like I said, the intent was to make sure to start at a baseline, to make sure we all have the same information and we know what's going on. I don't want to assume that folks know or don't know. And then once we're on the same page and have the same understanding about what the issues are, then figure out, now what do we do? And how do we do it? And more importantly, how are we gonna pay for it? Because it's not cheap to do this. So I'm sorry, was there another question, or can we have a?
I want us for the breakout rooms.
All right, before we move, I want us to be mindful of time. We got about 20 minutes left. With that 20 minutes, do we really have enough time to be able to go into these breakout rooms for solutions? And then the other question is for our participants, do you just want to go over the time? So we like to be respectful of people's time. This is supposed to be a 2-hour session, but if people are willing to engage and continue with this conversation, then by all means, we can definitely keep it going. But we do want to make sure everybody's okay and we're respectful of their time as we go through this process.
So, Okomfo Nsia, how long were you planning on having participants in the breakout session? Because I think if it was meant to be just to get ideas going, then I think 20 minutes would be enough time. So
originally, I wanted to do 20 minutes and then in the session, and then 10 minutes for the reporting out. So I think that will put us about 10 minutes over our time if we still do that.
And I suggest that we just have that conversation right here in this room. And this is the beginning of a conversation. This is not the end. This can just be the beginning, and this could be continued at another time.
So how about 10 or 15 minutes?
Yeah, look, so let's the reason I wanted to break everyone out is because there's 52 people on this, and I think it just will be more manageable and let everyone have a voice if we break it out, and then we can reconvene and share our ideas. I will then collate those ideas, and if people are interested in getting behind this effort, I'll follow up with you, and then we can start from there.
So how about we do this? So how about it's 3:43 right now. So how about we give people roughly 10 minutes just to talk. You could type the ideas into the chat, and then you will have whatever people came up with in the chat. We can even get 15 minutes with that. How does that sound?
I really want to do the breakout rooms. I think
that's what I'm saying. So
okay, yeah, so people can
15 minutes. So so everyone's going to go into a breakout room now for 15 minutes. We ask that you do have a recorder, and that recorder can type the information in the chat or take notes, and we will give you an email address to send the information to. And so you will be going into your breakout rooms in just a moment. So you will have 15 minutes. And there will be 4 breakout rooms. Okay. And there
go. If you can unmute yourself. So let me start off the conversation. My general thoughts is, I think that is great for us to provide some aid and assistance to our brothers and sisters on the African continent. But I think we need help right here in America in terms of stuff that we need to be able to do. So
True.
the NAB, the Non-Culinary Advisory Board, which really is Nana Boucher and Nana Bakan have been pretty instrumental in dealing with that group. They have always done these little projects that are associated with helping Latte and trying to get them their water project, their road project, and things of that nature. So as a community, I think we all can get behind that in terms of trying to be able to support some of those efforts, because we realize that things are dire. But as they say in the plane, if you're in the plane is, you lose your oxygen, you got to take care of yourself first. And then after you take care of yourself, then you put it on the person that's next to you, or the child, or whoever that's with you. So I think that it's great to have this conversation. But for us as a community, we need things here right now to make us whole, because we're in the belly of the beast and we're fighting a whole bunch of stuff. We don't. Those are my thoughts.
Lacey, I agree with you. It's a fever, a noon.
Quasi, I agree with you too. This is Akuya Ajima, and I totally agree with you. We need a lot of help here, especially with our children being pushed into school. I'm just very upset about that, and I'm working with some people around that, school nurses and all. So yeah, I agree with you. We need help here. We need to help ourselves too, and I would like to help all those Okomfos and people who are reaching out to the diaspora, Ghana, and help. I would love to help them too. So.
Me Pacho, this is what Tarpon. What something I learned a long time ago is we are most familiar with our enemy. We live next to them every day. We work with them. We understand their method and their means of controlling us. And it's important that when we make trips to Africa to communicate with our family, with our folks there about what is happening and how they utilize these means to control and use us. So with all the health conditions we have, you know, the diabetes, the heart conditions and all of that, yeah, we have to get control of our stuff. We definitely, but we also have to let them know, make it clear, these are not your friends. This is not your family. They might come looking or in a spirit of trying to help, but they come to use you to benefit themselves, and that's one message we need to communicate. I think that's the first step, and that doesn't take any money. That doesn't take anything, you know. But to sit down and talk.
Brother Quadro, I mean, I agree in terms of having that conversation, but the mentality of our African brothers is quite different from ours in terms of how they perceive Europeans. So they run their own countries, and they know some of the atrocities that even their own leaders do to their own people. So even Africans that come to America, when they go back to Africa, they don't tell them the truth. They don't tell them how hard it is living over here. They don't tell them all the challenges that they have living here. They're going over there with wads of money, giving people money, act like they're living in a big life when they live in an apartment with 10 people in it, and they struggling just like all of us are. So I agree. Yes, we can go over there and say that, but the chances of that being believed, I don't know. They're like, oh, you're trying to, and the mentality of the African is like, oh, you're just trying to keep it for yourself. You don't want to share what you have got. But the Africans that come here perpetuate the same thing. They come to America and they go back to Africa and do the exact same thing.
I agree with you wholeheartedly. You know, I'm not saying anything
Yeah.
different than you, but we have to start somewhere. You know, we have to be present.
It's got your what?
Auntie Afiba, you're not muted.
Oh, sorry.
No, I was just saying that I agree with you wholeheartedly. I'm not going to take up a whole lot of time, but you know, that is the reality. Everything that is the reality, but we have to, and it starts with a conversation. You know,
As a healthcare professional, I'm thinking of it in terms of with my patients. I'm unable to focus on our differences. I still have to provide empathy, compassion, and care, no matter what the differences are. And I feel like if we focus on our similarities and we focus on our unity, yeah, we are able to come with a unified front. As long as we continue to divide by complexion, by religion, by choices of diet, as long as we find the things to divide us, it's just going to maintain the same, it's going to perpetuate the same things that are happening right now. So I think coming together in unity is definitely one of the biggest things that we need within our community. I mean, each one of us. So if each one of us is maintaining that type of mindset, then it becomes cumulative.
Hey, Palcho, I just want to make sure that someone is recording for your group.
Nana Kwesi?
Nobody's recording, but you know, we got the general feel. Everybody,
You started it.
Everybody.
You started it.
Okay, I'm gonna leave y'all to it.
Get out.
It becomes painful because it's so deep.
Yes.
It becomes painful because it's so deep. So hearing the brother
Yes.
talking about I mean, we know what the oppressor, we know what colonization has done to us across. I mean, we're talking about trying to heal ourselves. And like you said, the colonization of Africa is so evident. So it's like,
I mean, I'm like, you know, I want something that's come across for me recently in terms of my thought about African people. They know that people from the diaspora have been, or they know about the Middle Passage, people being taken from there, all type of stuff. But from a political perspective, you would think that they would, or the African governments would be arms open to African Americans or people in the Americas coming back to those countries. But we've had those experiments take place and they haven't been very successful for a number of reasons, because we're coming back over there much wealthier than the native people who were there, which that within itself creates division. So, I mean, it's a complex issue. It's not something, I mean, this conversation is definitely not going to solve it. We can definitely start building towards it, because it's so complex, because we have people and personalities involved. And then, you know, you have some bitterness as well in terms of just some of us, in terms of how we're treated when we go there. We're not called Black brothers and sisters. We're called bronies. We're called white people. We're called foreigners. I don't identify like that. I identify like, yo, brother, what's up? I'm glad to see you. I'm glad to be back home. So, you know, I mean, this is a really complex issue from a psychological perspective in terms of just how do you create that? I mean, you know, you have all the levels of enslavement, all the psychological damage that we've incurred for centuries as a people, and unraveling that is not going to be no overnight situation. So even if we go over there with $1 million, $2, $3, $10 million or whatever, to go over there to try to make the country a better country, I mean, what does that mean?
most of us have a common ground. Most of us have a common ground. When we go to work, we got our work voice. When we were in the hood, we got our hood voice. Most of us can chameleon ourselves. We can change ourselves according to the environment we're in. We have to learn to do that with each other. We know how to be humble with the wrong in the wrong situations, unfortunately. And it's like, okay, why do we know how to do that for people who don't matter, but the people who we care about, we speak to like you ain't shit. Excuse my language, family, but I just feel like on a broad spectrum, we do it. We and not even smaller. We make ourselves smaller we correct ourselves to fit in certain puzzles. But when it comes to our own puzzle, we're fine with being on the outside and not quite fitting in. And I feel like it's so simple to find that common ground. I think that's just that is a start.
One critical piece in the conversation is the work. So we have to observe what they need. What I think is very powerful is when you go to the land, when you go to the village, you got to pound cassava like they do. You have to pound cassava like they do. That is powerful because one of the things that I observed in Ghana when I was there is they don't waste time thinking about, okay, what do I need to do? They get to work. You see them, they are working 24/7. They are making things happen. They're doing what they do. And I think that we have to follow suit. There's a lot for us to learn in that conversation. You know? So, but we have a lot to lend as well. And we have to be conscious of that.
In the communities of Ghana, you see each person has their specialty. Each person has their contribution to the whole. So that's where the 1 + 1 + 1 + 1 + 1 + 1 + 1 equals however ones I just said.
We are not tourists. And we got to keep that in mind. We don't go there to be a tourist. We go there to work. That's what it's. We got to go there to work, and we got to recognize them as family. You know, those are our folks, and we got to help them to understand that we're not bronies. No.
It's a each one teach one.
Yes, 100%.
All day, every day.
And with your actions. So
with your actions,
it's each of us behaving a certain way, like you speak of Kwesi Amoa. Each person maintaining specific character. Each person doing these things makes the whole better.
It's true. It's true. And it's not a quick solve. And we also have to have the right intentions in our heart. You know, not going with that colonial mentality of I'm here to save you. You know, but that I'm here to share. You know, when you talk to me, I mean, that's what I do when I go to Ghana. I sit around and talk to folks. And you have to make sure that you come in humbly. And you come, like you were saying, you know, Kwesi, you were saying before, you got to be humble. And you have to have the right mentality and the right intention. And not thinking you there to share. I mean, to say, you know, you ain't a savior.
Right.
Worldview is round, it's cyclic. Our traditions are cyclic. Your view is I'm giving to you, you give to me. It's linear. So if we function from that cyclic place of reciprocate, you give, I give, we share, we
yes.
That's it.
This is what you need, but what do you need?
Yeah. I can do this, you can do that, let's put it together. I will always remember the way I bought it in Ghana. You can't do that here if you didn't have money.
Yeah.
It's cyclic, and the mindset
But I 100% agree that we have some of the same issues in terms of global health here in our own community. And you got to start at home.
Yes.
You got to start at home first.
Yes.
Now everyone's coming back in from the breakout rooms. What we're going to do now, we are at 4 o'clock. So this will go over by no more than 10 minutes. If you would like to stay in the call, please do so. If not, we definitely understand. We would like to give each group 2 minutes max to present out. Any suggestions that you can have, you can email them to akomkese16@gmail.com. I'm placing that email address in the chat right now. So for breakout room 1, if you can, that includes Aquia Samuels Gilchrist, Ama Nsia Fortawa, Amaduma Bidiako, Dana Amaserwa, Efua Benton, Mami Yaya, Nana Abba Ncio Perry, Natalie Aguara, Okomfo Efua Duku, Valerie Kahembe Aquaberger, and Ya Ncio Perry Phillips. If you can have one person to present out, and I'll put on a timer for 2 minutes.
Good afternoon, everyone. And I took the notes, so I'm just going to read them. I put them in the main chat so everyone can see them. We just brainstormed ideas, doing a needs assessment, using African and African American medical field personnel, formulate a group within ourselves, community resources from us, by us, health situations underscored, realistically consider what is happening in our communities right now. Both places we are needed, both places meaning here and in Ghana, and our problem solving is necessary here first. Critical to have self-education in order to be cooperative, to participate in the educating of the issues. Similarities of health issues in both countries, start small, then branch from there to address the commonalities. Engaging youth while in school, cocoa farmers, many who harvest are children, maybe spread the word about that exploitation and the health risks connected to that profession. Having an economic impact, database of healthcare professionals within the Akom community. Supplies can be shipped, and youth being encouraged.
Okay, thank you. Now we have breakout room number 2. That includes Abimbala Wali, Amoa Apari, Kofi Fojo Tyus, Nana Efua Nsia Asantewa, Nana Esidena Zulu, Numu Tigare Kwabena, Okomfo Kwabena Anine, Shayla BG, and Ya Apari. And I will start your 2 minutes. If someone can share out a summary of the discussion.
It looks like Nana Efua is speaking, but she's muted.
Nana.
Oh, okay, I'm sorry. We were happy to see the Okomfo engaged in this discussion. One suggestion was to start a philanthropic effort with spiritual help to back it. Another was that this issue is global, not just on the mother continent. We need to use our shrines to perform rituals first, identifying what needs to be done. Get some of our people with money to assist, like ball players and others. We need to consult our shrines as to what can be done. I'm glad our Okomfo are being educated to know some of the topics to share with the shrines. Get in touch with influencers and start a blog to inform people around the globe. Those were the things.
Great, thank you. Awesome. Breakout room number 3. Those participants are Afiba Anum Amoa, Kafensi Chike, Kwajo Sarpong, Kwesi Amoa, Lenora Abena Anine Walters, Nana Aquia Ajamine, Rukaya Afiba Nsia, Stella Maglor, Tasha Russell, and V40 Thin Q. And your 2 minutes starts now.
So our general feel, unless somebody else wants to talk, I will yield. Afiba, you want to summarize everything?
You got this.
All right. Our general feel is that
You got this.
that the general scope of the conversation is that we really need to be getting ourselves together prior to helping Africa as such. I don't think that we're opposed to it, but we as a group, we need so much self-help in terms of the things that we need to accomplish and we need to do here. So one of the things that was mentioned was like with Nana Boitre and Nana Bakan, where they're doing these water projects and road projects through the Nana Economy Advisory Board for Latte. I think as an Akom community, that's something that we can probably get behind and support in a small way. But some of those larger issues that are going on, we need to first have ourselves, fix ourselves, get ourselves straightened out before we could be of really any assistance to anybody else. And that's part of what we're doing.
Hey, thank you for that. And finally, breakout room 4, Efua Nsia, Akosua Bakeman Giaboa, Akuya Johnson, Ama Nyamache, Ama Willock, Okomfo Kosua Durawa Radford, Okomfo Boachua, Okomfo Efua Nsia, and Sura Anoche. If someone can give the summary, and your 2 minutes begin now.
Okay, I'll make it quick because I know our time is short. So we had very similar comments to the other groups. I guess the part, just to summarize, I think it would take a multifaceted approach, starting with the most important thing being a needs assessment. And us as an Akom community, each of us has direct connections with communities on the ground in Ghana. And so we have access to people that we could start a needs assessment with, identify who would be the relevant people to talk to get a project like this underway, and really go from there. We talked about not needing to wait. We don't have to wait and ask for permission to talk to our people, because we have other people who have gone in without asking permission and have done other things. And so we can go in and talk to our people. We talked about, we went kind of into some of the detail about what it could look like, and it would maybe engaging students here to do some type of travel study seminar as a part of it. And yeah, and just a multifaceted approach. So I'll stop there so that we can save a little time.
Awesome, thank you so much. Thank you everyone. Thank you Okomfo Efua Nsia for a very informative presentation on a topic that I myself haven't heard much about in the Akom community. So it's very appreciative. I definitely learned a lot and definitely helped me to evaluate ways that we can support. And I think from what I was hearing from the comments, looking at gathering a coalition of professionals who are interested in this topic, perhaps, and starting some kind of brainstorming group, exploratory group in terms of how Akom can help might be a great start. Again, if you have any ideas or suggestions, please email them to us at akomkese16@gmail.com. I'm going to let Okomfo Efua Nsia have the final remarks.
Yes, first of all, I just want to say thank you all. I know this was a long session and there was a lot of information shared, so I appreciate your patience and your willingness to work through this with me. And for, I believe it was group 4, I wanted you to know that your suggestions resonated with me. I did have the opportunity to work for an African-American-led, woman-led NGO that did exactly that. University Hospitals in Cleveland, Ohio once had a program where we sent OBGYNs to train physicians in Guyana, in South America. Guyana, believe it or not, only had generalists. They did not have OBGYNs, and they had a very high infant mortality rate because of this. And so that training partnership has been in place, I believe now for 6 years. So it's a partnership between a university here in the US and with Guyana's largest public hospital in Georgetown. And I'm looking to do something similar. And so definitely, I think that approach is what it's going to take. And then as far as addressing issues here, I agree with that 100% as well, but I think we have to do both. And that was one of the approaches with the African American led organization in Cleveland. Cleveland has a very high infant mortality rate. They have a lot of lead poisoning from paint factories in the city, and just serious health disparities in the city of Cleveland. And so while we worked internationally, we also worked in our local community. It is possible to do both, and I think it's necessary to do both. And we have enough people to make that happen. So again, I want to say thank you. And I want to definitely see us not just follow up, but do. Organize, think about this, strategize, and come up with solutions that we operationalize for our communities here as well as in Ghana. Thank you.
Awesome.
So let me say real quick. So this is Okomfo Efua Nsia. This is something that she's passionate about. It's just something that she's leading up as as a member of Akom Kese board. So we're, as an organization, there's more than enough projects that people are passionate about that can be supported. Only thing you need to have is really some type of organizational structure in order to be able to do that. So as a Akom Kese board, we support this effort, but we are only 8 people. We need other hands involved in this situation. So since Sloan Efua is leading this effort, she's going to be the person or be the point person for us in terms of leading this effort, in terms of doing things. So if anyone is interested and wants to contribute to this and you're passionate about it the way she is, please, let's lock our hands together and move towards that effort. And whatever those little projects that we can focus and support, eventually they'll become big projects, but it has to start somewhere. So this is the first step in that conversation.
And I would also add, it has to be organized and it has to be well informed and everybody on board, and everyone, we can't be siloed and people doing little projects all over the place. It needs to be a coordinated effort. It needs to pull resources. And the one thing we didn't talk about was the money. And so going forward, we need to talk about how do we fund this. That will be a main topic of conversation going forward.
Again, thank you all for joining this meeting, this session. Again, if you are interested, if you know this is a passion of yours, or that you have skills and time and effort you would like to give to this effort, please email us or type your name in the chat and just say you'd like to be part of, Akom Kese's Global Health Initiative. We definitely appreciate everyone's time and for being able to stay on. So until tomorrow, may Onyame walk well with you all, and we will see you. Thank you. Madasi.
Thank you.
Thank you, everyone.
If y'all want to just hang around and talk, you're more than welcome to do that. We'll keep the session open, and I guess as people fall off, we'll then shut it down. But you're welcome, to stay on and walk with each other.
Real talk.
I'd like to talk to Sister Lucina. She's still on.
I'm here.